Good evening. Good evening, dear students. So I hope I'm audible, um, and I hope you have been enjoying the previous oral and maxillofacial surgery sessions. So today I'm here with a very important topic, uh, that is internal derangement of TMJ. So this topic is, I completely understand at your level it is a little difficult to understand. All right. So I have simplified this topic in a way that it would be easier for you to understand and also answer easily in your examinations. So I will be giving you notes. You can take down the notes, and I also have a few diagrams to make you understand the concept better. So we will start with this topic, that is internal derangement of TMJ. All right. Now, to start with its basic definition, please write down. It is the disruption of internal aspects of TMJ. It is a disruption of internal aspects of TMJ in which an abnormal relationship exists between the disc condyle fossa and articular eminence. All right. So what do we understand by this? इसमें इंटरनल डिरेंजमेंट ऑफ टीएमजे में क्या हुआ, जितने भी सारे स्ट्रक्चर्स हैं जो जॉइंट बनाते हैं, ऑलराइट, ऑल द स्ट्रक्चर्स दैट आर एसोसिएटेड विद द जॉइंट, be it the disc, the condyle, the fossa or the articular eminence, all of them are in an abnormal relationship. All right, they are not in the normal relationship, they are in an abnormal relationship. All right, so that is the basic definition of internal derangement of TMJ. Now we will come to the etiology. All right, now your etiology can be due to micro trauma and macro trauma. Just write down, I'll explain. So your micro trauma can be bruxism, parafunctional habits, all right, hypermobility of joint, and macro trauma can be history of trauma to the joint, trauma to the condyle, and osseous morphologic changes. All right, so the etiology of internal derangement can be either due to micro trauma or macro trauma. In micro trauma, we have bruxism, parafunctional habits like nail biting, lip biting, all right, and hypermobility of joint. And hypermobility of joint, just nothing but your dislocation, all right. And macro trauma, there might be any history or history of direct impact to the joint or osseous morphologic changes. By osseous morphologic changes, we mean basically arthritis in which the morphology, either the condyle will have a different shape or the glenoid fossa will have some morphologic changes. So basically structural changes. By osseous morphologic changes we mean structural changes. Now what are the associated changes and symptoms of internal derangement? Please write down associated changes and symptoms of internal derangement. There will be pain during function. There will be reduced mouth opening. Okay. There will be masticatory tenderness. Please write down, I will explain. There will be cervical tenderness. Synovitis. Adhesions within the joint. There can be hemorrhage in joint space. There can be degenerative changes in the joint. By degenerative changes we mean osteoarthritis, and there can be tearing of retrodiscal tissue. So these are either the changes or symptoms that can be present during the process of internal derangement, or if a patient is suffering from internal derangement. Now pain during function, there can be pain on mouth opening, there can be pain on chewing, there can be pain during opening and closing movements. Mouth opening might be restricted. Masticated tenderness, so while chewing the patient will have tenderness in the joint. Cervical tenderness, this region, the cervical region will be tender. There can be synovitis, that is inflammation of the synovial membrane. There can be adhesions within the joint. Adhesions I have explained during my class when I have taken TMJ disorders in detail during my regular classes. There can be hemorrhage or bleeding into the joint space. There can be degenerative changes like osteoarthritis, and there can be tearing or perforation of the discal or the retrodiscal tissue. Alright. Now internal derangements are also of various types. Alright. Internal derangement is also of various types. Now please divide this heading into two. So type A is disc displacement and type B is structural incompatibility of articular surface. Structural incompatibility of articular surface. Now disc displacement can be of two types. Please write down. The first one is disc displacement with reduction. Alright, disc displacement with reduction. The second one is disc displacement without reduction. Okay, and under structural incompatibility of articular surfaces we have adhesions, we have alteration in form, nothing but structural or osseous changes. The third one is rheumatoid arthritis. Now we are only concerned with disc displacement with reduction and disc displacement without reduction. Alright, so these are the two most important things that we will be discussing. Alright, so let's discuss these in detail. And these are the two most important conditions from where questions can be asked. Alright, before we go into the details of these two conditions, just I want you to note down important points and please write down anteromedial displacement. Anteromedial displacement of disc is more common. Alright, this is an important point. Anteromedial displacement of disc is more common. Alright, now okay, there is something known as normal physiomechanical disc to condyle relationship during translation. Now this, what is this? We will see this with the help of a diagram. Alright, so I have the diagram with me and I'm going to explain it to you with the help of diagram. So I have arranged some very basic diagrams for you people. So don't get confused. The diagrams that I have are not very fancy diagrams. They're very simple diagrams जिसमें डिस्क और कॉन्डाइल का रिलेशनशिप समझना है. कुछ टेक्निकलिटीज हैं डायग्राम्स में which are not correct, but that I will let you know. But there are very simple diagrams which I want you to understand and take a note of this. These diagrams will be available to you in this video also, and they are also available in the workbook 1 that I have given during my class. These particular diagrams are also available in workbook 1 given by me to all of you during your classes, during your regular classes, those of all who have attended the regular class. Okay, so don't worry, these diagrams are available to you in workbook 1. Okay, now just let us see. I'm going to use a colored pen. Okay, this is figure 1. In figure 1, this is your resting face. Alright, here the joint is at rest. Okay, the joint is at rest. It is in the resting phase. This is your articular eminence. This is the disc which is already marked. This is the condyle head. Okay, and this is the glenoid fossa. Okay, so there is the glenoid fossa, there is a disc, and then there is the condyle. Alright, now this is at rest. This is at rest. Just look at the relationship of the condyle and the disc. This is how the disc is present in relation to the condyle. Alright, this is how the disc is present in relation to the condyle. Okay, now you can actually ignore picture 2. Here what you can see, actually mouth opening movements have started. You can actually say that mouth opening movements started. So what will happen? The condyle will move forward in the glenoid fossa and the disc will also move forward along with the condyle. So basically what is happening, the condyle is moving forward in the glenoid fossa and along with the condyle the disc is moving. So basically क्या है, एक synchronization exist कर रहा है between condyle and glenoid fossa. One synchronization is existing between condyle and glenoid fossa. So the condyle and disc are moving together in synchronization and they're moving forward in the glenoid fossa. Like you can see in picture number 3, the disc has moved forward and the condyle has also moved. जितना disc और जितना condyle move कर रहा है उतना ही disc move कर रही है. They are in synchronization, they are moving in tandem. Alright. Now this 4 is the point of maximum mouth opening. Maximum mouth opening. Alright. इसके बाद what is this? This articular eminence will restrict the movement of the disc and condyle further. तो क्या हो गया आपका maximum mouth opening आपने कब achieve की? Just look at my mouth. Okay, you have achieved this when the articular eminence has created a stop in the path of the moving disc and moving condyle. Alright, this is your maximum mouth opening. Okay, now here between figure 4 and 5, closing movements have started. Alright, closing movements have started. So what is happening? The disc is going back in the glenoid fossa and the condyle is also going back. Again they are going back in synchronization. वो दोनों इकट्ठे साथ में हाथ, very simple terms में समझो, साथ में हाथ से हाथ मिला के साथ में condyle और disc glenoid fossa में वापस जा रहे हैं. Alright. Now again in picture 6, further closure. Alright, further closure, again disc is moving back, condyle is moving back into its original position in glenoid fossa and they again return back into the resting phase. They again return back into the resting phase. Alright, so just go back and revise, open this video and revise along with the diagram. And you can also open this diagram in the workbook provided to you people. Alright, you can do the markings in your workbook also. Alright, now we will again go back and we will now see anterior disc displacement with reduction first. First we will see anterior disc displacement with reduction. Now I have tried to simplify this in a way that you will understand very clearly. So on what जो भी important points हैं, I will make you write down so you can take down the notes. Please write down. Disc is present anterior to condylar head. Okay, just write down, I'll explain. There is pain during mouth opening. Alright, there is pain during mouth opening. There is click on opening and click on closing. There is click on opening and there is click on closing. Now this click on closing is also known as reciprocal click and it is less noticeable than opening click. It is less noticeable than opening click and कुछ cases में ये जो क्लोजिंग क्लिक है या रेसिप्रोकल क्लिक है वो नोटिसेबल भी नहीं होता, लेस नोटिसेबल होता है या नहीं, it is not noticeable also. All right, so this is a question. Click on opening, reciprocal click, all these are your questions. Okay, click is not always audible. Click is not always audible. But dental surgeon can feel during palpation. Alright, so पेशेंट बोलेगा नहीं मुझे कोई जाउंड साउंड नहीं है, मुझे कोई क्लिक नहीं होता ओपन करने पे, क्लोज करने पे, बट जब द क्लिनिशियन पैल्पेट कर रहा है या क्लिनिशियन एग्जामिन कर रहा है पेशेंट को, he might be able to palpate the click during TMJ examination. Alright, now during opening, what is happening during opening? Click क्यों हो रहा है? Click is due to first write down during opening clicking or popping sound. During opening clicking or popping sound, please write down, it is due to disc reduction. अभी जैसे पहले डायग्राम से समझाया था नॉर्मल फिजियोलॉजिक फंक्शन, आई विल एक्सप्लेन दिस ऑल्सो इन द डायग्राम सो यू विल बी एबल टू अंडरस्टैंड. ड्यू टू डिस्क रिडक्शन व्हेन कॉन्डाइल मूव्स फॉरवर्ड और ट्रांसलेट्स. ओके, जस्ट राइट डाउन, अभी लिख लो, आई जस्ट मेक यू अंडरस्टैंड. नाउ व्हाट इज हैपनिंग ड्यूरिंग क्लोजिंग? व्हाट इज हैपनिंग ड्यूरिंग क्लोजिंग? Reciprocal click as condyle returns to original position, gliding over posterior part of disc. जस्ट राइट डाउन, मैं डायग्राम से एक्सप्लेन करूंगी. ऑलराइट, ऐसे समझ नहीं आएगा. अनदर, प्लीज राइट डाउन, आफ्टर इनिशियल 10 mm of mouth opening, after initial 10 mm of mouth opening, there is deviation to affected side. Alright, there's deviation to affected side. Now I have explained the concept also behind in which conditions deviation is towards affected side and in which conditions deviation is towards the normal side in my class in detail. So I would want कि वो concept भी जाके revise कर लेना. Alright, so now we will go to our diagram. अब आते हैं एंटीरियर डिस्क डिस्प्लेसमेंट विद रिडक्शन. ठीक है, ठीक है, ये हमारा डायग्राम है. जो पिक्चर नंबर 1 है वहां पे हमारा कॉन्डाइल रेस्टिंग में है. ऑलराइट, नाउ प्लीज अप्रिशिएट जो ये है, जो फिगर नंबर 1 है जो मैंने अभी रेस्टिंग मार्क किया है. जस्ट लुक एट द पोजीशन ऑफ द डिस्क. आई वांट यू टू फॉलो माय पेन. ये डिस्क का पोजीशन देखो, ये कॉन्डाइल के एंटीरियर है, ग्लिनोइड फोसा में, ग्लिनोइड फोसा में. ठीक है, ये कॉन्डाइल के एंटीरियर है. condyle is posterior. ठीक, all right. Otherwise it is, in the previous diagram we had seen that this is not how it is. All right, it is supposed to be in synchronization with the condyle. ठीक है, just remember it in very simple terms. Okay, so अब क्या हुआ, इंटरनल डिरेंजमेंट की डेफिनेशन इस डायग्राम से भी समझ लो. देयर एग्जिस्टेड एन abnormal relationship between the disc, condyle, glenoid fossa and your other structures of TMJ, right? And articular eminence, because articular eminence के relationship में भी disc abnormal position में in relation to articular eminence also. Okay, so this is what is internal derangement. जो सारे structures joint comprise कर रहे हैं, या sorry जो joint बना रहे हैं सारे structures, they are in an abnormal position to each other. Alright, now here in this mouth opening movements have started. ठीक है, माउथ ओपनिंग मूवमेंट्स हैव स्टार्टेड 1 to 2. ऑलराइट, तो क्या हुआ, डिस्क आगे गया, कॉन्डाइल से और दूर भाग गया, कॉन्डाइल उसके पीछे धीरे धीरे ट्रांसलेट करना स्टार्ट कर रहा है. ऑलराइट, ओके, जस्ट कीप फॉलोइंग माय मार्किंग्स एंड माय पेन. यू डोंट नीड टू गो इनटू द एग्जैक्ट डिटेल्स, कहाँ क्या कैसे प्रेजेंट है. ये डायग्राम बहुत हेल्प करेगा एंड में रिविजन करने के लिए, क्विक रिविजन करने के लिए, and you will not even have to read the theory also. Okay, now here again there are further mouth opening movements. ठीक है, further mouth opening movements. तो डिस्क और कॉन्डाइल, डिस्क और कॉन्डाइल फर्दर मूव कर रहे हैं. सेम चीज फिगर 4 में भी हो रही है, सेम चीज फिगर 4 में हो रही है. दिस हैज मूव फॉरवर्ड, दिस इज ऑल्सो मूविंग फॉरवर्ड. ओके, नाउ हियर माउथ क्लोजिंग movements have started. ठीक है, अब माउथ क्लोजिंग मूवमेंट्स हैव स्टार्टेड, तो क्या हुआ, डिस्क विल स्नैप बैक इनटू इट्स पोजीशन. जिस पोजीशन में वो पहले थी, रेस्टिंग फेज में थी, जहां पे डिस्क थी, ये उस पोजीशन में चली गई, यहाँ पे जहां मैंने एरो मार्क किया है फिगर 5 में. अभी ये धीरे धीरे कॉन्डाइल मूव कर रहा है, बट पहले डिस्क रिड्यूस होके अपनी एबनॉर्मल पोजीशन में चली गई. तो यहां आता है सॉरी दिस 5 में, दिस इज नॉट माउथ ओपनिंग, माउथ अभी ओपन ही है, सॉरी. ऑलराइट, माउथ ओपन ही है, बट क्या हुआ, यहाँ पे डिस्क हैज गॉन बैक इनटू इट्स abnormal position. Disc has gone back to its normal position, so this is, but mouth is still being opening click. ठीक है, ऑलराइट. डिस्क रिड्यूस हुआ बट कॉन्डाइल फॉरवर्ड मूव कर रहा है, डिस्क रिड्यूस हुआ बट कॉन्डाइल इज स्टिल मूविंग फॉरवर्ड. ठीक है, सो दिस इज ओपनिंग क्लिक. नाउ यहाँ पे माउथ क्लोजर मूवमेंट्स है. 6 में माउथ क्लोजर. सो व्हाट इज हैपनिंग ड्यूरिंग माउथ क्लोजर, डिस्क तो रिड्यूस हो गई अपने पोजीशन में, बट कॉन्डाइल इज मूविंग फॉरवर्ड. एंड आई एम गोइंग टू शो यू विद अनदर पेन. जब क्लोजर के टाइम में यहाँ पे कॉन्डाइल, जहां मैंने शेड किया है, ऑलराइट, यहाँ पे व्हेन दे विल कम इन कॉन्टैक्ट, दिस इज नोन एज, ये जो पॉइंट जब पोस्टीरियर मोस्ट पोर्शन ऑफ डिस्क पे दिस विल कम इन कॉन्टैक्ट, this is known as reciprocal click. click or closing click. When the condyle comes in contact with the posterior aspect of the disc during mouth closure, that is known as reciprocal click. Alright, and after that it will go into the resting phase. Again, I am trying to tell you that these are not very technically correct diagrams. Alright, there are some discrepancies in this diagram, but I have taken the help of these diagrams to make you understand, because there are simple diagrams. Alright, there are simple diagrams. So anterior disc displacement with reduction. I will explain again. I am going to explain again. So because I know this is a difficult topic for all of you to understand. So I am going to use another pen. I am now going to use a green colored pen. Okay. So ये जो है resting phase. Alright. ये जो है resting phase है. इसमें if you see जो condyle है और जो disc है, जो condyle है और जो disc है, they are in an abnormal position. The disc is anterior to the condyle. The disc is anterior to the condyle. Okay. Now, mouth opening movements have started. Disc forward. Condyle is moving forward. Alright. But जो disc है वो condyle से पहले आगे भाग गई है. Alright. It is not in synchronization with the condyle. It has moved further ahead of the condyle. Alright. Now there are further mouth opening movements and disc is further moving forward and condyle is following the disc. If you see, condyle is following the disc. ये posterior aspect है और यहाँ condyle है. Alright, they are not in synchronization. They are not in synchronization. Okay. Now here you can say further mouth opening movements are taking place and disc is further dislocated. Alright, disc further forward movements have taken place and condyle also has further moved forward in the glenoid fossa. Still there are mouth opening movements. Now then you can say when maximum mouth opening has been attained, the disc, it reduces back. It reduces back into its abnormal position in the glenoid fossa. Alright, it reduces back while the condyle is still moving forward. Alright, during mouth opening, the disc gets reduced back into its abnormal position into the glenoid fossa. जिस position में वो resting phase में first figure में था. Alright, तो यहाँ पे ये जो disc का reduce हुआ उस movement पे एक sound आएगी which is known as opening click. Alright, now during mouth closure what will happen? During mouth closure क्या होगा? Disc reduce हो गया but condyle वापस जाएगा अकेला. Condyle वापस जाएगा अकेला glenoid fossa में. So there will be a point that it will contact the posterior aspect of the disc. It will contact the posterior, the one that I am shading. तो यहाँ पे जब condyle disc को contact करेगा at its posterior aspect, so there will be a reciprocal click or closing click. Alright, and after which the condyle and disc will return to its resting phase. Alright, so you can come back to this video, come back to these diagrams, and you can follow the pen, follow the diagram and understand and keep this in your mind. Alright, now coming to now we will come to anterior disc displacement without reduction. Alright, we will come to anterior disc displacement without reduction. Alright, सबसे पहले please write down disc interferes with condylar translation. Just write down. मैं again diagram के उससे explain करूँगी so that it is easier to understand. There is limited mouth opening. There is limited mouth opening. So there is trismus. There is trismus. Now this is a question. This is a question. Okay. If patient tries to forcibly open mouth further, यानी कि जिस पॉइंट पे जहाँ पे माउथ ओपनिंग लिमिट हो रहा है, ओके, उसके बियॉन्ड अगर पेशेंट फोर्सिबली माउथ ओपन करने की कोशिश करेगा तो उसे क्या होगा? पेन. देयर विल बी पेन एंड देयर विल बी deviation of mandible towards affected side, that is जिस side का joint affected है, alright, towards affected side. Alright, this condition can progress towards perforation of disc. ठीक है, इस कंडीशन में डिस्क परफोरेशन भी हो सकती है. ओके, okay, Moniruddha, this topic is internal derangement, as I told, and I will be covering it in the class only if time permits. That's why I've taken out special time for covering this topic here in the YouTube session. I will definitely cover this topic if the time permits in the class. Okay. Now let's come to the diagram. This is anterior disc displacement without reduction. Okay, anterior disc displacement without reduction. Okay, now I am zooming out. This is the resting face. This is the resting face. Okay, now I want you to understand. All right, this disc, just look at this. This disc is in a very, very abnormal relation to the glenoid fossa, to the condyle and to the articular eminence. All right, all right. So what is happening here in this particular anterior disc displacement without reduction? I just wanted to, you don't need to go into details, एक बहुत ही सिंपल तरीके में याद रखना. ठीक है, here mouth opening has started. ठीक है, just remember, it might not be technically, details might not be correct in the diagram. Just remember, जब mouth opening start हुई है, disc is present in its position, the condyle is moving. All right, the condyle is moving, there is further mouth opening. All right, it's further mouth opening, disc इसी position पे है but condyle move कर रहा है. All right, condyle यहाँ पे move करेगा and at this particular point, the disc will stop or cause hindrance in further mouth opening. All right, disc will stop or cause further hindrance in mouth opening, and at this particular point जहाँ disc posterior aspect पे या condyle के या disc कॉन्डाइल के कांटेक्ट में आएगा, this beyond this point mouth opening will not be possible beyond this point, as it will cause a hindrance and there will be pain, and also there will be pain. ये फिगर नंबर 3 डिस्क है, उसने अब कॉन्डाइल का फर्दर मूवमेंट स्टॉप कर दिया, वो हिंड्रेंस बन के बैठा है कॉन्डाइल के पाथ में. ऑलराइट, वो बोलेगा कॉन्डाइल यू कैन नॉट मूव फर्दर, आई एम हियर टू स्टॉप योर पाथ. सो दिस beyond this mouth opening will not be possible, and beyond this if patient tries to open the mouth, forcibly tries to open the mouth, patient will experience severe pain. And beyond this, if the patient continuously tries to open their mouth, they can also cause disc perforation. So इसके बाद क्या होगा, patient will be forced to close the mouth closure. Further open नहीं हो रहा तो mouth closure, and the condyle will go back, but the disc is at its position where it was causing hindrance. Alright, condyle will go back due to hindrance. Condyle को रास्ता नहीं मिल रहा आगे जाने का, so condyle will not go further, mouth will close and they will come back to the original resting phase. Alright, so just with very simple diagrams, just remember this concept. You don't need to go into the details. Alright, you don't need to go into the details. Now one or two few more points regarding treatment and what are some other causes for all of this. I will quickly make you all write down. Okay, now there are certain systemic joint diseases causing internal derangement. There are certain systemic joint diseases causing internal derangement. Alright, there can be degenerative pathology in articular surfaces. Now that means there can be degenerative pathology either in the glenoid fossa or the condylar head. This is osteoarthritis. Apart from disc, the other causes of internal derangement. Alright, inflammatory rheumatoid arthritis, juvenile rheumatoid arthritis, ankylosing spondylitis, Reiter's syndrome, lupus erythematosus. Just remember the names, don't need to go into the details, just remember the names. Infective arthritis, it can be bacterial or viral. Alright, ये सारे, these are the causes apart from the disc. These are the causes of internal derangement apart from the disc. Okay, now treatment part. The treatment part. Alright, so all conservative treatment of MPDS, I'm not going to write that again here. जितने भी मैंने क्लास में ट्रीटमेंट ऑफ MPDS के अंदर जो सारे कंजर्वेटिव वाले स्टेप्स लिखवाए थे, एनाल्जेसिक्स, हीट एप्लीकेशन, कोल्ड एप्लीकेशन, टेंस थेरेपी, वो सारे जो मैंने 7-8 पॉइंट्स लिखवाए हैं, ऑल्सो ऑल कंजर्वेटिव ट्रीटमेंट ऑफ MPDS. ऑलराइट, प्लस Apart from that, what you can do? Arthrocentesis. Again, arthrocentesis I've taken in detail in the class. Arthroscopy. आर्थ्रोटॉमी. आर्थ्रोटॉमी में क्या हो सकता है? डिस्क रिपेयर और डिस्क lication. Again, I have told this in the class. And discectomy. Just the names, you don't need to go into the details, बस नाम याद रखने हैं. मोस्ट इंपॉर्टेंट इसमें से कुछ पूछा जाएगा तो वो आर्थ्रोसेंटेसिस पूछा जाएगा, which I have already taken in detail in the class. All right. डिस्केक्टमी अगर हम करेंगे तो हम क्या करेंगे? Autologous. We have to replace the disc also. So autologous. Autologous graft और disc replacement. Again मैंने glenoid fossa interpositional arthroplasty में glenoid fossa lining materials बताए थे. Those particular things will be and condylotomy, that is reshaping of the condyle or removing a portion of the condyle. All right, not removing the entire condyle, basically reshaping the condyle. Okay, condylectomy is not a treatment option here. All right, condylectomy is not a treatment. Condylotomy. Okay, now I had seen a question somewhere. Okay, so there is a difference between deviation and deflection of mandible. Difference between deviation and deflection of mandible. Okay, now just write down, I will explain quickly. If there are any doubts, you can ask me in the comments below. Okay, deviation and deflection. Now, deviation is movement away from midline followed by return to center. Alright, followed by return to center. Okay, now deflection is movement away from midline. Movement away from midline without return to center. Just understand this with the help of a line diagram. Deviation में क्या हुआ? Mouth open हुआ, center में open हुआ, थोड़ा सा deviate हुआ and वापस से center में आ गया mandible. Alright, follow these arrows. This is deviation. Mouth open हुआ, midline में open हुआ, maintain हो रही है midline, फिर वो deviate हुआ एक side पे, further mouth opening पे वो वापस से center में आ गया. Alright, okay, this is deviation. Now what is deflection? Alright, what is deflection? Center में mouth open हुआ, alright, but it goes on to one side and does not return to the center. It does not return to the center. Alright, now I will give you examples of both of these. इसका example है internal derangement. Alright, now the example here is capsular adhesions and partial TM joint ankylosis. Now, what do you mean by partial TM joint ankylosis? Fibrous ankylosis mein, I have taught also in the class, fibrous ankylosis mein there are certain movements that are possible, certain some amount of mandibular movements are possible. तो partial ankylosis में क्या होगा, जब आप माउथ ओपन करोगे वो एकदम से डिफ्लेक्ट हो जाएगा, ऑलराइट, वो डिफ्लेक्ट हो जाएगा, एंड when the patient will close the mouth also, it will not come in the center, it will remain deviated or shifted towards one side. Again, go and revise the visuals जो मैंने वर्कबुक 1 में TMJ एंकाइलोसिस में दिखाए थे. जब पेशेंट का माउथ क्लोज्ड है तो भी वो एक साइड पे है, ऑलराइट, एंड पार्शियल और जॉइंट एंकाइलोसिस में क्या होगा, ओपन हो रहा है तो भी डिविएट हो रहा है, और जिस साइड डिविएटेड है उसी साइड डिविएटेड रह रहा है, बट मिड लाइन में वापस नहीं आ रहा है, ऑलराइट. दैट इज also called as deflection, where the mandibular movements do not return to the midline. The mandible does not return to the midline, alright, on movements. Alright, so this is the topic that we have covered today, internal derangement of TMJ. With this we complete the topic. So I want you all to revise this, make your notes. I know it is a little difficult topic to understand, but don't worry, you can always ask me the doubts, and if time permits I will quickly take up this topic in the last, during the remaining classes. Alright, during the remaining classes I will take up this topic briefly in the last, because we have to cover quite a few topics still. So if time permits I will take this up again. Alright, so but I want you all to please make notes of this topic, so that even if I am covering this topic in the class, we are able to cover it quickly. And it may be possible that I will just be covering only the diagrams in the class. I will just be covering the diagrams in the class. So I want you to all have the notes of this and my previous topic, impactions, that is available on YouTube. Just make down notes of these topics, so that we are able to spend less time on writing down this when the class is happening. Alright, so I think with this I can end my session. If there are any doubts, I'll wait for 5 minutes. If there are any doubts, you can ask me in the comments below. So I've tried my best to simplify it. If there is still any doubt, I will take up in the class. So I hope everything is clear. So I think we will end the session here. Thank you so much. Thank you, students. Happy studying, keep revising, and I shall meet you again soon. Thank you.